How could this happen? Well, what I've got drawn for you here is baby weight gain in grams per week. That's what this is. Versus gestational age going from 22 to 42 weeks. 42 weeks? No. Anyway, so starting at 42 weeks, at 22 weeks, the peak in fetal growth, I'm sorry if you don't know this, but it's 33.5 weeks. Even though mothers feel the baby continues to grow into a giant monster inside them, even with diabetes especially, in fact, the growth rate tapers off, tapers off, tapers off. So if we don't get started treating these babies before they get to 33, 34 weeks, we've already had half the body mass accumulated on this child. How does this work? Well, so first of all, if instead of at 24 weeks you order at 26 or 27 weeks, you order the glucose challenge test, and of course it takes the patient for a while to get it done, and then it gets reported back to the office staff. The office staff ordered the 3-hour glucose tolerance test maybe 2 weeks later, and the patient drags her feet getting into that, but now she's got a positive 3-hour test. She goes into the class, because that takes a week or 10 days to get to the class, and learn how to check her blood sugars, and do you see what happened? The baby has already become fat before we do anything for it, before we start the meds. And so the way we may be doing things here may just be destining us to have a baby that looks like that. So let's clutter our brains a little bit with the hyperglycemia and adverse pregnancy outcomes study, the HAPO study. Now, Boyd Metzger, who put this monster of a study together, I just can't tell you how much I admire him for being able to get 15 centers in 9 countries. So we couldn't accuse, oh, you did this in one little dinky population, you used an inner city population, you had healthy Swedes from Minnesota. No, we have everybody involved. 25,000 women in 15 centers in 9 countries. We are talking about the human race. Everybody got a 75-gram test, even the ones in the United States, administered at 24 to 32 weeks. And if you had gestational diabetes, you're not in the study. The people in the study are the women who don't have gestational diabetes. So their fastings were less than 105, and they had no 2-hour values less of 200 or higher. So these are non-diabetics. And so let's just go to the next thing. The trial outcomes were, the primary outcome was birth weight greater than the 90th percentile. Now that should be only 10% of babies, right? 90th percentile. So only 10% of babies should be in that category. Neonatal hypoglycemia, some other really important things that can tell us about babies being fat. They're fat, they're hyperinsulinemic, they're hypoglycemic. We're looking for those kids. And secondary outcomes, we're actually going to measure neonatal fat mass. Okay? How did it turn out? Okay, so what I'm showing you here is blood concentration. I've just chosen the fasting blood sugar. Now, they all took the test. These are women who passed the test. This is their fasting blood sugar across the bottom. And you can see it goes from 75 up to 100. And this is the frequency with which the outcome measure, either baby birth weight, percent baby body fat, or the cord insulin level, C-peptide insulin level, to what was the percentage above the 90th percentile. Now, so you would figure above the 90th percentile should be 10%. So sure enough, if your fasting blood sugar was 85 or less than 85, then all the baby outcome measures were less than where they should be predicted, about 90%. But look what happens if we allow the fasting blood sugar that we pass and say, it's okay, ma'am, you have a negative test. If we decide 95 is an okay number, 20% are born fat. If we decide 100 is an okay number, then 30% are born fat. They're born fat, they have high insulin levels, they're probably programmed for childhood and adult obesity. And these women were told they didn't have diabetes. So it makes you think that we should change the way we diagnose diabetes. So the Think group got together using these results, the International Association of Diabetes and Pregnancy Study Groups, got together and said, okay, how would we do this so that those babies that were being born fat could be offered some kind of treatment? And so they came up with the following. using a rule that says if your likelihood of being fat was not quite doubled, 1.75 times increase in being born fat, then any one of these values, fasting 1 hour or 2 hours, less than these hard to remember odd numbers. Now I will tell you there was a lot of argument and discussion and angst trying to get roundable numbers, and whenever you rounded the numbers you let more fat babies through. To just use a fasting, you let fat babies through. Use a fasting in 1 hour, fat babies got through. So in the end, the group decided this is the right way to do it if you're trying to protect humans from becoming fat in utero and maybe fat for life. And so those are the numbers for the 2-hour test. And the IADPSG, and we just talked about, consisting of all these organizations, came together and said, use the 2-hour test with any single abnormal value making you have the diagnosis of gestational diabetes. So they recommended, please, first visit, check for type 2 diabetes, okay? And if they have it, treat them. Diagnose prediabetes in the intervening group, the group at the first visit that have elevated but not critically elevated numbers. And then finally, everybody be diagnosed with just using the 2-hour test with the numbers that I give you at 24 to 28 weeks. Well, that sounds pretty good, except the fact that when you take the HAPO population and go back and look, okay, if we start doing the 2-hour test and all these people using these cut points, what will happen to the percentage of people who have gestational diabetes? And guess what? It somewhere goes up by 50 to 100% over baseline. So that means if we use the new criteria, we may have to double the number of patients we see. Ooh, that's terrible. Ooh, that's expensive. And yet, is it okay to let these babies be born fat? That's what we don't know the answer. So the arguments against the switching to the one-step test are that, first of all, a label that may stick with you for life, gestational diabetes, that an oral glucose tolerance test has poor reproducibility, and it's true. In fact, it's been shown that if you do your oral glucose tolerance, if you do your glucose challenge test, by the way, in the afternoon, you have a much higher likelihood of passing it than if you do it in the morning. The oral glucose tolerance test depends on carbohydrate loading the night before and all kinds of other things. It's a problem. The other arguments are shown here that the biggest one is the bottom one, is the bottom two. Quote-unquote, overdiagnosis of gestational diabetes may result in overtreatment, expense, and medical stigma. Now, no study has shown anything but the opposite, but, we haven't studied this population before. So where will we go? The arguments for doing the switch are that we're letting all these fat babies get through. And failure to modify our testing regimen fails to recognize how many people have become now obese in our population, and that we need to consider that in our criteria. So the National Institutes of Health convened a consensus panel. Now, what a consensus panel is, you get a bunch of smart experts who are not in the diabetes world. They're smart about something else. They could be smart about aspects of pediatrics. They could be interested in placental function. They could do some, but they're brilliant doctors, but they don't do diabetes. They don't have a dog in the fight. In preparation for that consensus panel, they convened a group, also supposedly, experts that are going to read the literature critically and come up with the evidence report that's provided to the panel. Then the panel will read the evidence report and listen to a bunch of speakers and try to decide what to do about whether to go to the one-step test or stick with the two-step test. Here's what the evidence report says. It supports the fact that maternal glucose levels and macrosomia and C-section and shoulder dystocia are linked, no matter which test you use. However, as you saw with that line from the HAPO study, there are no clear thresholds about, oh, if we choose this, we'll get this. We're always going to let some fat babies through unless we treat everybody. And secondly, that the treatment of gestational diabetes results in less preeclampsia and macrosomia. So that was the good news, and that's what the evidence report said. So they tossed it now to the committee. Oh, and two other things. But the current evidence does not show that GDM treatment affects or prevents neonatal hypoglycemia. And at least the studies that have been done that stop monitoring the children after they're born have not confirmed this continuity that I've tried to describe for you. So they think we don't have evidence showing the continuity that if you're born fat, if you're fat inside your mother, you get born fat, that you'll be fat later. And then there's little evidence, but there's also little evidence of short-term harm. So now the panel meets, and this is what they said. The two-step approach is largely restricted to the U.S. In other words, to be honest with you, the whole world does a one-step test. And the whole world has now pretty much switched over to the one-step test with the values recommended by the IAD-PSG. And the panel agreed that having a single consistent international diagnostic standard would be great. However, the one-step approach is anticipated to increase its diagnosis of diabetes, gestational diabetes, up to as many as 1 in 5 pregnant women. And that this would be difficult. It would generate additional and indirect healthcare costs, the labeling of newly gestational diabetic women who weren't labeled in such a way. It may increase C-section and NICU events and cause life disruption and psychosocial burdens. Now, we don't mention the fact that, we're labeling a third of our women as obese, and we're expecting them to have the increased cost, life disruptions, and psychosocial burdens of this. But, that's what the consensus panel came up with. Okay, so since it's not clearly cost-effective to do the one-step test, they affirm continuing the two-step test. So here we are, the NIH versus the world, or the NIH, in our case, versus California. So we, like many centers in California, switched when the Diabetes and Pregnancy Program adopted the IAD-PSG values, and I just wanted to show you what we found. Here's the protocol that we use, and this is really taken it's constructed from the data that are on the CDAP website, that at the first prenatal visit, you obtain hemoglobin A1C and fasting plasma glucose, and if it's more than 6.5 hemoglobin A1C or fasting above 126, then she's an overt type 2 diabetic and she needs to be treated. If she passes both hemoglobin A1C and fasting, she gets treated at 24 to 28 weeks with a 2-hour test. Any one of these values that she meets or exceeds, she is now treated as gestational diabetes. Now, what do you do with this group in the middle? Nobody, and actually CDAP doesn't specify what to do with these people. They are the so-called pre-diabetes group, and we, in our world, have decided to treat these, and which is what IAD-PSG recommends, is treat them as gestational diabetes. Because, let's face it, these fastings, yikes, those are pretty high. Even though they're not 126, they're pretty darn high. So we have moved these patients in, and I want to show you the results from that.